buenas tardes. En nombre del Centro de Investigación Científica y de Educación Superior de Ensenada, el CICESE, de su director general, el Dr. Federico Greff, y de todo el equipo que realiza la publicación electrónica TODoS CICESE, que estaba antes y que cumple 15 años, les damos la más cordial bienvenida a esta conferencia acerca del presente y del futuro del periodismo científico en la frontera. Tenemos como invitado especial, como ustedes saben, a Jon Cohen, a quien damos la más cordial bienvenida. Jon, thank you very much for being here and being part of our celebration. Sin mayores preámbulos, los dejo con este periodista de ciencia que publica, entre otros medios, en la prestigiosa revista Science, y quien durante los últimos 30 años ha hecho una cobertura muy especial acerca del problema del SIDA en el mundo entero. Jon, thank you.
Hola, muchas gracias. It's okay, I can walk around. ¿Habla inglés? Más o menos, porque bueno, es más fácil poner en inglés ni español, es malo, es sucio. Cuando hablo en español, difícil. Hablo en español, okay, ambos un poco. Por muchos años escribes sobre VIH-Sida en muchos países, más de 40 países. Pero yo tengo un proyecto ahorita en Tijuana, almost por un año. No. I'm going to talk about HIV/AIDS around the world, not just Tijuana, but explain the many opportunities that exist right now and the many scientific studies that have occurred that have found proven ways to help people, what's being done and what isn't being done. So that's why it's aspirations and challenges. So right now we're at a moment in time when many leaders around the world are talking about ending AIDS epidemics in locations, not for the whole world, but ending an epidemic in a place like Tijuana or in a place like San Diego. And we're talking about AIDS-free generations. The President of the United States, Barack Obama, has been promoting this idea that the next generation won't have AIDS. And there'll be zero new infections. We'll get rid of discrimination. These are all aspirations. Nowhere has an epidemic ended. But we're starting to see incredible progress. We know the recipe. We know how to do it. We have very good tests for HIV, for tuberculosis, for other sexually transmitted infections. In 1981, when AIDS first surfaced in Los Angeles, it took 4 years before we had a test on the market to even detect HIV. We've had that test now for 30 years. That's the first place you need to start to end an epidemic of any infectious disease. You have to be able to test for it, to know that it's there. We know that if we give injecting drug users clean needles and syringes and give them opiate substitutes like methadone or buprenorphine that don't require needles, that we can stop the spread in injecting drug use. New York City has more injecting drug users than anywhere in the world. It has stopped the spread, basically, in New York City. We know that condoms work if people use them, and they're available. We know that circumcision protects men from becoming infected if they get circumcised. We know that antiretroviral drugs both prolong people's lives who are infected and also reduce the chance of their spreading the virus to another person if they take the drugs and they take the right drugs. And we also know that uninfected people who take antiretroviral drugs, just like people who take pills for malaria, who go to a country that has malaria, can prevent themselves from becoming infected. We have very good tuberculosis drugs that can cure TB in 6 months in most people. And we have very good monitoring devices that can test people to make sure that the drugs are working okay. We've seen this phenomenal, can we go back one? Yeah, this phenomenal surge in funding to help people help their own people. In 2000, there was only about $1 billion spent on helping people in low and middle income countries. By 2008, that had gone up to about $16 billion. That's an enormous increase in funding. Mexico has benefited from this because it's received money from what's called the Global Fund to fight AIDS, tuberculosis, and malaria. It's given Mexico a lot of money. many other countries have benefited as well. You don't see surges in funding like that for health very often. That's $1 billion to $16 billion. It's up beyond 20 billion now today. We have, when antiretroviral drugs first were developed that actually worked, which they first came to market in about 95 and 96, a year course of drug for an infected person cost about $15,000 a year. That's still what it costs in the United States. But generic manufacturers started to make the drugs very cheaply. These are factories I visited in Thailand and Brazil. India has been very involved with this as well. They can treat a person for a year now for about a little over $100. It's cheap. But everything takes too long. This is a clinic in Haiti, in the mountains in Haiti. These people slept at the clinic. They woke up and got in line to see the doctors. This is a line to see the doctors. These are HIV-infected people waiting to see a doctor. It's a very good program, but they're overwhelmed. All the people you're going to see now are dying from AIDS in the era after good drugs existed. These are all people from, say, 2002, 2003 forward. The United States has had good drugs since 95, 96. We can just click through these. I just want to show you all over the world that this is a problem. This is Dominican Republic. These are all people who had no access to antiretroviral drugs. This is in Myanmar, this is in Peru, this is in Guatemala. This is also in Guatemala. TB goes along with HIV. The diseases move together. They're actually a syndemic. They're really best thought of as one disease. TB is responsible for most HIV death in the world, and HIV makes you much more susceptible to an active case of tuberculosis. If we're going to attack HIV, we have to attack tuberculosis at the same time. If you do one without the other, the person's still going to die from TB. A vaccine would be the best solution. I wrote a book that came out in 2001 about the search for an AIDS vaccine. It's now 13 years later. There is no vaccine for HIV, and there's nothing that's moved that far ahead in clinical trials that tells us that we're going to have a vaccine anytime soon. It's a very difficult problem. If it were an easy scientific problem, a vaccine would exist. But a vaccine has the potential to remove a virus from the earth. The smallpox virus only exists in laboratories now because of a vaccine. And we've seen polio disappear in most countries of the world because of vaccines. Condoms are critical, but their impact is limited. I was at this brothel in Guatemala City where a transgender woman was teaching female sex workers how to use condoms, and it took her 3 times to put the condom on that dildo appropriately. I was shocked. I had just assumed that a sex worker at a brothel would know how to put a condom on. She didn't. If you don't put a condom on properly, it doesn't work and it doesn't prevent infection. The guys who were lined at the door in the picture were having a great time watching this. Testing and counseling and education, they all work. They're incredibly important. This is a van that parks itself outside of gay bars in Hollywood and does testing on Friday, Saturday nights. If somebody tests positive, they refer them to care. They help them get the care they need. That's all very smart. It's great. But it has limited impact. Harm reduction is the idea of giving people clean needles, getting them onto opiate substitutes, helping them with their mental health problems, helping them reunite with their families. But it's used very spottily. This is in Puerto Rico, which is really part of the United States. She's giving him clean syringes. Look at his foot. That's a foot that likely will be amputated. It is not harm reduction to simply hand him clean needles. He needs medical care. Societies from Mexico to the United States to Russia, everywhere I've been, have a really hard time accepting the fact that they have people who inject drugs. These people are hated. They show up in emergency rooms and they're sent away. That's not how you stop HIV. It's not how you help people. Next one, please. This is in Manipur in India at a drug treatment center. He's chained to his bed. This is not humane. This is unethical. This is not harm reduction. This is a human. This is not a dog. That's what we would do to a bad dog. That's not how you help somebody who has a heroin addiction. Until 2005, we only had one biomedical way to stop HIV. That was to give pregnant women who were infected antiretroviral drugs, and that prevents transmission to their babies. This is a clinic in Uganda that found a simpler way to do that. This intervention was proven to work in the United States in 1994, and it was proven with an intravenous drip of AZT that the mother had to receive in labor, that the mother had to receive the drug from 36 weeks out. It had no applicability to much of the world. But this clinic showed that by giving a single pill of the drug nevirapine to the mother and the baby in labor, they never have to show up for prenatal care, you could cut transmission by about 2/3. It wasn't perfect, but it was a great advance. But until 2005, that's all we had. And then we had this phenomenal rush of great news. It was shown that male circumcision in 3 huge studies prevented spread to men by about 60%, reduced their risk. It was shown in several studies that people who took antiretroviral drugs who were uninfected, just like the malaria pill, had incredible protection if they took their medication, up above 90%. And it was found that treatment in a study in Uganda, given to an infected person, reduced the risk of that person transmitting to their regular partner by 96%. This trifecta changes everything. It really does create an opportunity to end AIDS with counseling and condoms and syringe exchange, with all the other things I mentioned. You put it all together and you have an incredible package. But there's a huge problem in Mexico and in the United States and everywhere else I've worked, where there's a reluctance to actually be self-critical, to look at what you're doing and to ask what could we do better. This is a group in Washington, D.C. called D.C. Appleseed. It's a group of attorneys who volunteer their time to criticize the city every year about their HIV program and their response. And they put out a report card every year. It's had tremendous impact in improving the response in Washington, D.C. It's not a perfect response, but it's a whole lot better than before this report started to come out. I would encourage every city to do this. This is the harsh reality. So I work frequently at an AIDS hospice in Tijuana that has about 100 people who live there. This man arrived I think he arrived 4 days before. He died December 12th. He was diagnosed with HIV in Loreto. He was put in an ambulance and driven 14 hours to this hospice to die. He was never given antiretroviral drugs. He never saw a doctor here. The hospice is very compassionate, very good people. They do not have a doctor on staff. It's the only hospice in Baja. We've closed all our hospices in San Diego. They don't exist any longer. This exists in Tijuana because of a systemic failure that needs to be looked at. Why does this hospice exist? It's a good place. I love the place. I think the people are doing a great job. But it shouldn't exist. It exists because of a failure. He died because of a failure. Had he been diagnosed in the United States, it most likely would have happened earlier. And when he was diagnosed, they would have done everything they could to have tried to prolong his life. It's not to say they would have succeeded necessarily. Some people show up so late you can't save them. But everything went wrong for this man. Did he contribute to it? Sure. He had a lifestyle that was a very difficult person to help. This is a man who showed up at the hospice in September. His name is Victor Moras. Victor has known he's had HIV for many years. By the way, I have people's permission to tell their stories, to show the pictures. Victor had been on antiretroviral drugs before, but had dropped off them. He's had several problems. He's been homeless for many years. He lived in Yungos, close to here in Rosarito. He lived in El Bordo. He had to have his blood sent from Capacit in Tijuana, which is at the edge of Tijuana, by the way. It's not in El Centro. He had to have his blood taken and sent to Mexico City to have it evaluated to make sure that his immune system had enough damage for him to be put on antiretroviral drugs. There's something completely wrong with that. Mexico has a guideline of a CD4 count of 350 per milliliter of blood before you start someone on antiretroviral drugs. Normal people have 600 to 1,200 who are healthy. The World Health Organization in June of last year came out with a recommendation saying the cutoff should be 500 to start people on drugs. Mexico still stays at 350. Mexico still sends blood from Tijuana to Mexico City for a blood test that can be done in Tijuana. That's all wrong. Victor started treatment in late November. He's okay. But that's not the way you treat people if you want to end an epidemic and you want to help people who are infected. The United States, I don't want to pick on Mexico, has a terrible record of getting people to the point where their virus in their blood is not detectable by standard tests. That's the goal. You want to be undetectable. You're still infected, but you want to be undetectable. In the United States, in July of 2012, we came out a report showing that we only had 25% of the people who were infected in the country who were virally suppressed. If you're not fully suppressed, you're going to transmit the virus. If you are fully suppressed, you're probably not going to transmit the virus. If you're not fully suppressed, you're going to get sick from the virus. If you are fully suppressed, your likelihood of getting sick diminishes greatly. So the United States calls this the treatment cascade. We have been self-critical and looked at this repeatedly from the White House on down to say, what can we fix here? Mexico, I don't know if Mexico has this diagram. Mexico should have this diagram. Every country should have this diagram. Every country should be addressing every step in this. What percentage of people don't even get diagnosed in the United States? I can answer that question. 18% of the people who have HIV in the United States do not know they have HIV in their bodies. That's a problem. You can't help them unless you know they're infected. What percentage of people in Tijuana have HIV and don't know they have HIV? I don't know. A lot? How about that? That's not an answer. Studies that have been done in Tijuana, and there are excellent people doing studies in Tijuana. There's a binational team that works from UCSD that has Mexican scientists working with an international group. They've done some studies of specific populations to look at what percentage know that they're infected, and it's low. It's in the realm of 50%, let's say. What percentage of people who are diagnosed in Tijuana with HIV are linked to care? I don't know. What percentage of people who are linked to care are retained to care? I don't know. What percentage of people are prescribed medicine who are linked to care? You have to answer these questions if you really want to address your epidemic. You have to be self-critical. Systems are overloaded when they try to do things right. This is in a part of South Africa that has a huge HIV burden. 33% of the pregnant women are infected. You'll see patients on the floor of this hospital. This government is aggressively attacking its problem. It's trying to do the right thing. It has more infected people than any country in the world, over 5 million. And systems become overwhelmed very quickly. So if Tijuana, if Ensenada, if Baja wants to really address its HIV problem, it has to have the system capacity to absorb what's going to happen. Because what's going to happen is stuff like this. You're going to suddenly not have enough beds in hospitals. You have to think ahead. The key affected populations, Mexico and the United States have epidemics that are not in the general population. They are in key affected populations. In some ways, that's much easier to control than what South Africa has, which is a generalized epidemic that heterosexual spread. Tijuana and Baja and all of Mexico and the United States pretty much have the same kind of epidemic. But these are people who are often ignored and often remain in the shadows. This is El Bordo in the Tijuana River Canal right at the border. There are about 1,000 people who live there. Many of them are deported, as is this woman from the United States. Many of them, because they're deported, don't have their Mexican documentation. They don't get Seguro Popular, or they have to wait. The services that are provided to them to help them stay healthy are less than you would want to see. I'm being generous. So you have a great opportunity for spread of HIV in that community. The United States has seen a shift of an epidemic from predominantly middle-class gay men to the epidemic has pushed over to the southern part of the United States, to African-American men who have sex with men, many who do not identify with being gay, even though they have sex with men. They're not part of a gay community. So there's been a big shift in the United States, and the United States has had to shift its focus to better address this population, to help them. Sex workers exist everywhere I've been. I've been to many countries where politicians have insisted that we don't have sex workers here. I've yet to see a place that doesn't have sex workers. Border towns often have very vibrant sex industries. Cunimán is on the border of Mexico and Guatemala. Tapachula borders Cunimán. Except the fact that you have sex workers. I mean, Tijuana is pretty progressive about that. It's zona norte, it's open, it's well known, and they even have a testing program. I'm not sure how well it works, but it exists. Let's be honest about it. The United States, for the most part, isn't honest about it. Transgenders are the most vulnerable people in the world to HIV. They typically have the highest prevalence in the order of 20, 30, 40% of the transgender community. They are more discriminated against than almost any group of people. They have very high levels of depression, very high levels of suicide, drug use. They are the most vulnerable people. What are we doing for transgenders? Is there, in Tijuana, in Mexico, in Baja, is there a clinic for transgenders? No. If you're a transgender in Tijuana or Ensenada, you really want to go to San Diego because there's a transgender clinic that specifically deals with the fact that you want to have breasts and you were born biological male. And what do people who identify as being women in Baja do who can't afford or don't have the papers to go to San Diego and they want breasts or hips? They can get because their needs. San Diego. To spreading the virus. What this program does is it has a testing van in the gay community in San Diego and Hillcrest that sets up and takes a person's finger prick blood and does a rapid test to see if they have antibodies. If they do not have antibodies to HIV, they take blood in a vial and they send it to the laboratory and they look for genetic evidence of HIV, which shows up very shortly after being infected. If that person is infected, they then ask that person who they've recently had contact with, sexually or through sharing needles, and then they try to contact all those partners. They try to break the back of the network that's spreading the virus. That's a very smart way to stop an epidemic. It can be done in Tijuana, it can be done in Ensenada. It requires resources, of course. It requires sophisticated laboratory techniques. But that's what the goal should be. And if it's not happening, why not? It's logical. In Xlavisa and KwaZulu-Natal, where they have that very high prevalence, they have a testing program that regularly goes to every house. and tests everyone. This woman, this older woman, who's not at high risk of HIV, and her daughter, they regularly get tests. They test positive, they get them into care. In Birmingham, the emergency room at the University Hospital, they test everyone for HIV, unless they opt out. This woman came in for a toothache, got an HIV test. In St. Petersburg in Russia, they have a mobile van that goes out to pick up homeless kids because homeless kids have very high HIV infection rates. And they test them where they are, on the streets. In Washington, D.C., at the Department of Motor Vehicles, they do HIV testing. They pull you out of line, they give you a $5 gift certificate or whatever it is, they keep your place in line, you get an HIV test. We have to make it easier for people to find out that they're infected. And we also have to make it easier for people to get the information they need at venues where sex transactions occur. In African American communities in the United States, there is a movement of, it's popular with men who have sex with men to be in these ballrooms or clubs where, in this case, you strut in front of a group of judges and you pretend to be different people. They're pretending to be heterosexuals. That's the contest. Every few minutes they change the contest. It might be schoolboys, the next minute it might be teens. Incredibly popular scene where a lot of people meet people that they have sex with. That table on the front there has condoms and pamphlets and information about HIV. That's a great way to reach people. In San Pedro Sula, Honduras, I worked with an outreach group that went out to the sex workers, both the males and the transgenders, out on the street with placards that have pictures of sexually transmitted infections. Do you have this? Do you know what this is? Doing real education, handing them condoms, telling them where they can go to a clinic. Go out to where sex is happening. In Tauranga, Botswana, they have things called shabin. They're drinking pubs, outdoor pubs with homemade liquor. This woman is there handing out both female and male condoms. People do sneak off into the bushes and have sex. That's how transmission occurs. That's reality. Face it, people like having sex. Poor people especially like having sex because it doesn't cost anything. It's free for the most part, unless you're buying it. Think about it. If you're really poor, sex is one of the things you can do just as well as somebody who's really rich. In many countries, they have ridiculous drug laws. Russia outlaws methadone. It is illegal for a doctor to prescribe methadone in Russia. Ukraine recently made methadone legal. Russia and Ukraine have epidemics driven by opiate injecting drug users. That's what spreads HIV there. When I was in Ukraine, this clinic was one of the only ones available with methadone. He's showing the nurse that he's actually taking the methadone. People sometimes steal it and hide it in their cheeks or whatever else and try to sell it. But when I was there, a doctor was arrested for providing opiate substitutes. Just because they can do stuff like that. It was crazy. As I mentioned, New York City has had an incredible effectiveness at reducing the spread of HIV in injecting drug users. They have a few dozen methadone clinics around the city. They have all these legal and exchange programs. It works. It works absolutely everywhere it's done. Australia is a phenomenal success story of preventing spread and injecting drug users because of needle and exchange and opiate substitution and counseling program that started in 1986 when the epidemic started. There are new diagnostics that are revolutionary in what they can do. There's a new TB diagnostic. The way TB is diagnosed, it often misses TB in HIV-infected people. The standard test, you spit up some sputum, it goes under a laboratory microscope. HIV-infected people often don't have a lot of TB in their sputum sample. It doesn't show up under a microscope. So you miss it. This new test, it's a machine called Gene Expert. It does a genetic analysis of TB and it detects all sorts of HIV that's otherwise missed, even detects drug-resistant TB. There's a new machine being used, this is just one example of it, called the Avid Architect, that looks at not just HIV antibodies, but HIV proteins. So it can detect people much earlier and start to break the back of, of that infectious network by identifying people within a few weeks of infection. And there are structural issues that are sort of breathtaking in their complexity, but they're also driving the epidemic, and we honestly have to look at them. Migration and deportation is a major factor that drives the spread of HIV. When you take people out of their normal environments, guess what they do? They mix with other people. They have sex with other people. They share needles with other people. That's going to happen. Let's be honest about it. Let's look at it. This is in Tapachula, Mexico, a migrant center right across the border from Guatemala, where they have AIDS education. They have HIV posters up. They have condoms. I think it's also interesting this is run by the church. The church has done many things to help HIV, but it's also done things to stop HIV. So I like to just point out that the church is a complicated place. Prisons are a great place to reach people who are HIV infected. First of all, they're there, right? They're not going anywhere. Doctor gets to see the patient. Patient's going to show up for every appointment. In this prison in Rhode Island, they have a very progressive program where they give patients blister packs so that you know each day which pill to pop. This guy came into prison, a very sick man with HIV. He's very healthy. He's doing really well. And he said to me, prison saved my life. Now the problem is for him, what happens after he gets out of prison? And we've seen lots of studies now that if you don't have a linkage to treatment and care when they get out of prison, bad things happen. So we need that as well. Mental health and homelessness are incredible drivers of HIV spread. If you don't care about living, you don't care a whole lot about your HIV or getting infected. These are two men who are in a public housing facility set up for HIV-infected men and women by the U.S. government, funded by the U.S. government, and gives them their mental health. One of these guys jumped off a bridge and tried to kill himself because he's a transgender, and he said that this housing saved his life. Drug dependency is an incredibly complicated issue, and many people who use drugs regularly live in places where they're hard to reach. He actually has lived in this hole off and on for 18 years. Very nice guy. And that's his syringe on the ground. We don't set up any further. It's hard to reach him. They're blessing him. They're two ex-users. They're not providing him any HIV care. And he knows about HIV. He's a smart guy. How do you help him? Well, first of all, get him a home other than a hole in the ground. Help him with his mental health issues. It's complicated. This woman lived under a freeway on-ramp, methamphetamine user in San Francisco for a long time. Very hard to reach population, but she's been reached by an outreach group at San Francisco General Hospital that specifically targets hard-to-reach people to help them with HIV problems. Mexico City has a very cool program. Violence against women is an enormous problem, especially sex workers. This woman is being observed across the street by an older sex worker who runs a program with her son to help the sex workers who work on Sullivan Boulevard. She's talking to the guys in the car if they want to have sex with her, if one of them does, or all of them do. They'll go to a motel. She'll get in the old woman's car, who will drive her there. The old woman and her son will time the encounter. If it goes on too long, they'll bang on the door, make sure she's not being harmed. The old woman and her son are connected to a sexually transmitted infection zone. These sex workers trust this woman. They'll let that older woman and her son get them into care. That's smart. This woman on the right in the window, a brothel in Pune, India, runs a union of sex workers so that they can have microloans for each other, they can get their kids' education. Most sex workers I've met around the world have children, and they care about their children. That's part of the reason they're selling sex. So she runs a program to help them have better finances and not become indebted to pimps or brothel owners, who then make it very difficult for them to make a proper living and take care of their health. In Haiti, when I was there before the earthquake, the man is a professional dancer teaching sex workers how to become professional dancers. So instead of selling sex, they can sell dance lessons, or they can sell themselves as dancers in clubs. It's a pretty clever idea about how to reach sex workers and protect them from HIV. So what are the challenges? The challenges are resources, leadership, and cooks. You have to have cooks. You have to have people who know how to apply the recipe. This is Hillary Clinton, who was then our Secretary of State in the United States, talking about delivering an AIDS-free generation. I think the United States has shown exemplary leadership, and I'm highly critical of my government and every other government. I don't particularly, there's a famous American author named H.L. Mencken who wrote in the 1920s and 30s about politicians and said that they are like garbage men. They all smell and we need them. And that's kind of my philosophy. So when I say a really commendable thing about a politician's actions, please keep in mind that I think they are like garbage men. But what the U.S. has done is taken a great leadership role in saying, here are the possibilities, here's how we as a country can do better. And I think that that's an example for the world. The health minister in South Africa right now, Aaron Motsoaledi, is another example. He has taken ownership of an epidemic and said the South African people will pay for their epidemic, will address this aggressively. I think he's been a remarkable icon for a lot of countries because he shows what's possible with determination and guts. This is the program I mentioned in San Francisco General Hospital. This is a nurse who basically does much of the work of a doctor, saves a lot of money, and she runs a team of outreach workers who work with the most difficult populations in the city to keep them in care. They have a team that does phenomenal outreach that is similar to what's done in Washington, D.C. This is an HIV-infected woman who works with the clinic. If you don't show up for your clinic appointment, she goes and finds you. She goes to your church. She goes to your home. She goes to your bar. And she walks in and she says, where have you been? You get in my car now. You get aggressive about helping people help themselves. This is a woman who works in El Bordo. Her name is Susie Leal in the yellow vest. She works with this team from UCSD and the binational Mexican program. Susie is a former user, been clean for 12 years, HIV infected. She's undetectable. She's been undetectable for 8 years. She works as an outreach worker in El Bordo. She lived in El Bordo for years. Everyone trusts her and loves her, and she helps get people tested and get people into care. We need hundreds of Susies. And Susie is a success story. And so the aspiration can be reality. She lived at Las Memorias at the hospice for a time years ago. That's her celebrating there at the party. She, to me, is an example of what's possible. And it takes an appreciation for people like Susie, to celebrate them, to bring epidemics to a halt. So thank you for having me here. I'm happy to take any questions. The photos are all my longtime collaborator, Malcolm Linton, who lives in Tijuana now, and none of this would be possible without Malcolm's contribution. Thank you.
Estamos transmitiendo por streaming, así que si van a hacer preguntas, por favor, el uso del micrófono es importante.
Well, first a comment and then a question. The Ward 10C in Vancouver's General closed a couple of days ago because the amount of rains in the city is really down.
I think you're referring to the Ward 10C in Vancouver, Canada. Yeah, that's not a first. They claimed it was a first. It's not.
They say they closed it.
Yeah, they did close it, and that's a great indication of the success they've had in Vancouver.
Yeah, and actually the doctors going out to the going out to the medication phase. The other thing that I'm a bit concerned about is that it seems that AIDS is becoming a outcast disease in North America, but in Mexico and other things. Well, places like Africa, South Africa, it's very common among the population. Doesn't that make it harder, since these people don't vote, for politicians to do something about it?
Sure, it does. I mean, diseases work in cycles in terms of the public's fear and in terms of expectations. When people are most afraid of a disease, it receives the most attention. People are most afraid when there's the most death and illness. So death and illness have declined, and that's why young gay men right now are particularly vulnerable, because they haven't seen a lot of death and illness in their community, and they are having high infection rates in populations that have tremendous services even, San Francisco, for example. So yeah, there's a decline, but it's cyclical. The really sad thing to me is the opportunities are greater now than ever before to intervene in ways that, like what happened in Vancouver, where they're shutting an AIDS ward. How do we address that? I just keep doing what I'm doing, and hope that other people who care about it continue to inform people about opportunities and about the progress that's occurred. But it's an issue, and these things will wax and wane, and this one has peaked. This one has peaked in terms of the attention it receives. Everywhere, people do become complacent. But it'll come back. If you become complacent, it'll come back.
I read somewhere that in the United States, the proportion of people with HIV in the United States, most of them are the gay community, and of the gay population, around 60% of the American gay people had HIV. I'm not sure if that's true.
No, nowhere near 60%.
No, sorry. I think it was 30%. Sorry.
Not that high.
No?
No. It can be in small communities, but it's not 30% as a country in any. It's nowhere near 30% in gay men. It's high. It's higher than other communities. It differs from city to city. The highest prevalence I know of is in transgenders, and that's approaching 30%. The transgenders is a small population.
Do you know the proportion, but in Tijuana or?
Well, that's the problem in Tijuana, is the surveillance is pretty sketchy. And it's sketchy both for practical reasons. It's hard to reach a lot of people. And there's an incredible amount of stigma regarding men who have sex with men in Tijuana, more so than in San Diego, in my experience. So many people aren't going to identify with their risk factors. They're not going to see themselves. So the surveillance that's done is in need of a lot of help. And I think people at the front recognize that. I think they know that. But I don't think there's any good figure you can put on it. The prevalence of HIV in gay men in Tijuana, there's been a few studies, very small numbers of people. They weren't properly randomized and done in ways that really provide compelling, randomized is the wrong word. They weren't properly structured in a way to get the best data. So I think there's a big question mark over that. But my guess is that gay men in Tijuana, other than transgender, most likely have the highest prevalence of any population. And there's a lot of connection with San Diego. Let's not pretend that this border is a border. I live in San Diego. I drove here today. I will drive home tonight. Yes, I am a privileged white American who has a century pass. But there are plenty of privileged Mexicans who have access to the United States. And there are plenty of Mexican gay men who go to the United States, who go to San Diego regularly. The border is a fiction for HIV.
You mentioned at the beginning the link of TB with HIV and how a lot of deaths are really because of TB. Is that the case in Tijuana? Is it mostly
Sure.
the people that are dying
Yeah.
of HIV is because of TB? Because
Yeah.
Baja California is number 1 or number 2 in Mexico with cases of TB. I wonder if that the link
Yeah,
is.
it accounts for more than 50% of the death here. I don't know what the actual figure is, but it's more than 50. It's probably in the realm of 60 to 75% of the death is TB related. And it's hard to treat somebody for both HIV and TB. Make no mistake about it. You can have an immune reconstitution syndrome occur that can kill you, because once you get your immune system back in gear and you still have TB, your immune system can overreact to the TB and kill you. So it takes a good clinician to know how to treat both diseases. But that's recognized and regularly done. It's called IRIS, and it's regularly done.
What do you do for writing important stories interesting, combining the scientific information with a good story to say.
I'm very privileged in that I've written for Science Magazine for most of my career, for 25 years almost. And my audience likes scientific information because it's called science. And I am given a lot of leeway that other journalists aren't given in terms of technical information that the public in general might not have an appetite for. But even for science, I try to write so that a geologist who doesn't really care about the things that I'm interested in will want to read my stories. And I try to mix personal stories with the scientific study. I love to get behind the scientific study when the scientific study has a result like, hey, people who, women who take antiretroviral drugs don't transmit the virus to the baby. I try to find a woman who has had that experience and tell her story and link her to the research if possible. I'm always looking, when I see a research paper published, I'm always asking, that involves humans, I'm always asking, who are the people? Can I meet the people? And I call the researchers and say, if you let your patients know, or the participants in the study know, that I want to do this story and I need their help, and please give them my contact information so I don't breach confidentiality. And then, often people call me and say, I'd like to help you, what do you want?
I was going to get back to this. These little exchange programs have become very, very important. I don't know how viable it would be in Tijuana. The other thing is, how would you, I think it's something that's going to be very important, is how would you approach this possibility of infection with avian influenza or porcine influenza and how it's going to approach humans? How would you approach a story like that could happen any time? I'm just thinking that if the porcine influenza is making more headlines in Mexico than HIV.
Yeah. Well, so in answer to your first question, there have been needle exchange programs. There are needle exchange programs. Unfortunately, Mexico funded its needle exchange programs through Global Fund money, and the Global Fund no longer will give Mexico money for HIV prevention because Mexico is too rich of a country. You may not know that, but you're now wealthy. And these programs have essentially scaled back tremendously since mid-December, and people I'm studying and following have been sharing needles a lot more. So there's a failure of the Mexican government to pay for something that clearly works and to take ownership. So why that exists, that's for you to find out. I've had trouble understanding that.
Except I was thinking that there was, the Hells Angels are also having needle exchange programs. Can we convince our pushers to do that here?
Well, I mean, communities that successfully address injecting drug use, by and large, are extremely creative and aggressive about how they reach those communities. They're very hard people to reach, and you're often doing things that the police aren't all that cooperative about. I mean, you have police in Tijuana, and I've not seen it, but I've been told this story repeatedly, who take bags of needles away from people, who have clean bags of syringes and harass them and shake them down. And as somebody said to me recently, I was in Indonesia recently with a bunch of injecting drug users, and this guy said, the police see us in ATM machines. That happens. So it's a challenge. The influenza story is of great importance, and there's a lot of interest in it. I don't see it as competing with HIV, though. I mean, it's just a separate story. It's an important story. It's compelling. And when H5N1 broke out, I stopped everything, and that's what I did for 6 months. And it was a fabulous story that had lots of misinformation, which made my job more exciting. It's really fun when journalists are getting things wrong to try to get things right. And there was a lot of misinformation about Mexico that occurred. And we talked about this earlier this morning, but the whole idea that there was a hog farm that had patient zero, and this community was where it all started because this American company was not blah, blah, blah. It was all a fiction. I don't know how that epidemic started. My guess is it started in the United States and came over here, and it didn't have a whole lot to do with farming practices here. There was no evidence that that's what happened. It made for a sexy story. And so as a journalist, a lot of what I'm doing is trying to get the best scientific information in, real time, as quickly as I can, and also to help correct the record if people who do what I do promote ideas that aren't scientifically sound. And that's sort of the fun of my job. I mean, that epidemic, I don't want to make light of it, it's a very serious problem. But reporting on that epidemic was really exciting. It was a breaking news story that just kept coming up with scientific riddles that people really couldn't answer quickly. How fast was it spreading? Where was it spreading? What was the death rate? And Mexico City had this, panic about the death rate. Everybody started wearing masks. Do masks work? I did a story about what's the value of masks for that matter. So I think the influenza story is going to remain an incredibly important story because of our increased ability to detect odd viruses. H5N1 wouldn't have been detected 10 years ago as readily as what the technology allowed that. And influenza is going to be the story of our next decade as these viruses keep jumping from birds and pigs. And they will. Of course, they always have. You can just see it now. And most are dead end. And most aren't going to wipe out the human population. And that one didn't. Well, thank you very much. I'm done listening to myself.
Bueno, si no hay más preguntas, quiero entregarle este reconocimiento a Jon Cohen. Tenemos un reconocimiento para ti de parte del CICESE. Que bueno, a la letra dice Centro de Investigación Científica y de Educación Superior de Ensenada. Otorga el presente reconocimiento a Jon Cohen por la conferencia magistral The Present and Future of Science Journalists in the Border. Firmado por el doctor Federico Gref, desde día jueves 29 de mayo.
Muchas gracias.
Y bueno, ahora los invitamos a un brindis aquí en la parte posterior. Los invitamos a seguir la conversación con Jon. Tenemos un brindis cortesía de la Asociación del Personal Académico del CICESE, a quien reiteramos nuestro agradecimiento, y un ambigú cortesía del CICESE. Que disfruten y que sigan disfrutando de esta presencia.